With the hip, we generally require more mobility. Obviously, in tasks such as a squat or a deadlift, we want to achieve that mobility to achieve the depth or the specific training task required. So that we're not compensating at areas such as the lumbar spine. Having said that, though, similarly to the shoulder joint, sometimes a control issue or a stability issue in the hip may actually be influencing the mobility. So often we need to address the stability to achieve range of movement increases at the hip joint. So when it comes to the knee joint, we're essentially viewing the knee joint as a hinge joint. Now, obviously, we do see some internal and external rotation occur, and this may influence movement, and it may influence muscle activation patterns, particularly in the hamstrings. But for the purposes of looking at our primary movement patterns, we see this as an area of stability. Now, obviously, if the knee has been injured, and we've actually lost some of that structural integrity, whether it be through a medial ligament injury, a rupture, or a partial tear, where we actually lose some of that frontal plane control, or in the case of an ACL tear, that will obviously affect the stability of the knee, and that will affect the muscular requirements and the movement requirements of the rest of the kinetic chain in order to compensate. The top of the ankle joint, the talocrural joint, is typically an area where we wish to see mobility. Obviously, the ankle joint complex, when we're performing more dynamic tasks, if there is a stability issue, or in particular a strength issue, lack of calf strength, for example, this may also influence movement. But in terms of our general resistance training, we want to see, particularly in the sagittal plane, particularly into dorsiflexion, we need to see adequate movement, because the dorsiflexion range of movement will often dictate, to a large degree, the quality of a squatting or other knee-dominant movement. In terms of the subtalar joint, whilst there may be some mobility restrictions in the subtalar joint, and this may particularly come on post-injury, in general, it's a joint where we want to see stability, particularly in resistance training exercises. We want to see that stability in the ankle, particularly in the transverse plane and frontal plane, as often a lack of stability at the subtalar joint will drive a position of eversion, position of pronation, and that may alter what's going on in the rest of the kinetic chain. So when we're looking at the metatarsophalangeal joints of the toes, in general, predominantly looking at the movement at the first ray, or the big toe. This is an area where we do want to see mobility. In some cases, we may see excessive mobility, but often it's a lack of mobility that affects that windlass mechanism, which is important in terms of lower limb force production with more dynamic tasks. We want to make sure that when we're performing movements such as lunges, split squats, any movement from that family, that we do have adequate back leg toe dorsiflexion, so that we're actually able to get into that position where both the toe and the ankle are moving into dorsiflexion. Now, whilst the joint-by-joint approach does provide a useful framework in which to view the kinetic chain and approach our mobility interventions, it's not a recipe approach, and there's a lot of cases where it doesn't work. So an example would be a knee, which typically requires stability. However, we might see issues arise with a lack of mobility, for example, in the proximal tibiofibular joint. So we've always got to, as we've talked before, view mobility in the context of that individual person and what's going on in their individual presentation. So when we're attempting to identify the most appropriate intervention to address mobility at a certain area, we should have some sort of modification procedure to guide that analysis. So for example, if we're trying to improve shoulder flexion range of movement, then we would obviously take an assessment, and then we would either apply a visual assessment so that we can see what's happening during the movement. We can try and see if there's some restriction through the thoracic spine that may be contributing it. Is there a lack of control through the lumbar spine that may be contributing to that restriction? And try and identify the area that needs to be addressed that way. We can also, obviously, in our subjective assessment, we'll identify some potentially past injuries. And if we know that an individual has had some issues with a specific area in the past that may be related to their current mobility restriction, then we can apply an intervention to that area and reassess the outcome. We may also apply a symptom modification procedure or mobility modification procedure while they're performing the movement. So as they move into shoulder flexion, we can, for example, perform an active thoracic extension and see if that improves their movement. We can apply a compression technique, a distraction technique. We can apply some isometric contraction of another muscle and just see either what visually improves their range of movement, or more importantly, what the individual feels, what the client feels, and how that changes their perception of range of movement. And then we can also simply trial some interventions. So if they have a restricted range of movement, then we may wish to address the thoracic spine. We'll do some specific thoracic mobility work, reassess, and identify whether that's an effective strategy or not. So we've covered range of movement assessments in a previous series, and it's important that they are performed to actually assess whether mobility restrictions are present. So an individual may perceive tightness with a certain movement or soreness with a certain movement, but that tightness or soreness may only be perceived at end range. So the person doesn't actually have a mobility restriction that prevents them from properly performing their relevant task. It's just that they feel tight at end range. We also may have cases where someone is hypermobile, so they've actually got a lot of mobility in a particular range, but they don't actually have the strength or the control to appropriately use that range of movement, and as a result, the muscles associated with that movement are overworked, they become overused, and then they become sore. So we've got to make sure that we're actually assessing for whether range of movement restrictions occur, and when they don't, properly educating the individual as to why they may be perceiving what they feel as tightness.